Hey folks, so I wanted to pick up where we left off with my last lesson. If you have not watched already, you might want to look at my part 1 lesson on the lower respiratory tract and its physiology. So that gave you some important background on the structures involved here, on how the lungs work, on the volumes of air moving in and out, how diffusion across the respiratory membrane works. If you've not consulted that video yet, you might want to watch it before you go any further with this one. Also, I recommend that you have a copy of my notes if you are in my Anatomy and Physiology 2 class. I've got the notes for this lesson posted to Blackboard. That will give you important terminology to reference as you go. You might want to have a copy of your lab manual or book open as well to have some diagrams to consult while I'm talking here. All right. So I want to talk now about the regulation of ventilation. How does our body control this process of breathing? Now, if you think back to your A&P1 class and your discussion of the nervous system, you know that breathing, like most of our background vital functions, is handled by the medulla oblongata at the posterior of the brainstem. The medulla oblongata has an area known as the medullary respiratory center. Medullary respiratory center includes 2 dorsal respiratory groups, which control contraction of the diaphragm, and 2 ventral respiratory groups, which stimulate the intercostal muscles, the abdominal muscles, and are involved with controlling the rhythm of your respiration. There's a third parts involved here that's not in the medulla oblongata. The pons also has a role in the regulation of respiration. The pontine respiratory group is involved in the switch between inhaling and exhaling. Its job is to basically keep the lungs from overinflating and then make you exhale at a certain point. Now, the medullary respiratory center is going to be getting data from multiple points. Obviously, it's getting data from receptors in your blood vessels that are sensitive to blood gas levels. You might recall when we talked about the circulatory system that I mentioned that you have several small organs like the carotid bodies and the aortic bodies that monitor the oxygen and carbon dioxide levels of your bloodstream. They send data onto the medullary respiratory centers to give it information about how deeply and how often you need to be breathing. You're also getting data related to body temperature and movements. As your temperature changes, your respiratory rate is going to change, going up at higher temperatures, down at lower temperatures. You're also going to find that your body movements are giving the medullary respiratory group something to work with. The more you're moving around, the more oxygen your body is going to demand. So that's going to stimulate more deeper and more frequent breathing. You're also going to get some stimuli from your emotions. Your emotional state will change your rate of breathing. You're probably all aware that you begin breathing harder when you're frightened, when you're angry, when you're sexually aroused. That can all stimulate increase in breathing rate. When you're resting or sleeping, your respiratory rate goes down. And also, you can get voluntary stimulus. The cerebral cortex can step in and override the background regulation and force you to breathe harder or slower. You can choose to take slower, more measured breaths. You can choose to breathe more slowly than the baseline rhythm. Likewise, you can choose to breathe faster. So we have a voluntary override, and we're going to talk about why that voluntary override exists in a few minutes. But left to its own devices, the brainstem will regulate your rate and pulse of breathing. It will control the in and out movement and the respiratory rate and depth. Now, normally what's going to happen here is that when inspiration begins, it's going to increase for about 2 seconds. You're going to breathe in under normal resting breath for about 2 seconds. Then the neurons that are responsible for stopping inspiration will be activated by the pontine respiratory group. There's a reflex that we call the Herring-Breuer reflex, Hering B-R-E-U-E-R, the Herring-Breuer reflex, which controls the switch between inspiration and expiration. So you breathe in for about 2 seconds. Herring-Breuer reflex kicks in to prevent overinflation of the lungs. And then this inhibits your respiratory muscles. You relax and you begin to expire. Expiration is a little bit longer than inspiration. In an averaging resting breath, expiration is about 3 seconds. So breathe in for about 2, breathe out for about 3. That gives you a 5-second cycle for a normal breath. And then you do about 12 of those per minute, and that gives you your standard respiratory rate of about 12 breaths per minute. Now let's talk for a moment about that conscious override, because unlike most of the other involuntary reflexes of your body, your brain can step in for this one. You can't choose to make your heart beat faster or slower. You can't choose to change the rate at which your kidneys are filtering your blood. But you can choose to control your breathing. You can voluntarily say, I want to breathe faster or slower or deeper or shallower. You can even choose to induce apnea, A-P-N-E-A, which is the cessation of breathing. In other words, you can deliberately hold your breath. So why, among all of our body's reflex actions, is breathing the one that you can step in and consciously control? A couple of reasons. First off, for vocalization. Whenever you want to control the sounds you are making, that means you have to control the way that air is flowing through your lungs, how much air is flowing, the volume, the force of it, how much is moving over the vocal cords, and when. That means you have to be able to step in and induce a new breathing pattern in order to make sure you're controlling the airflow in a way to produce the vocalizations that you want to. So our ability to speak, to sing, to shout, to scream, any of those voluntary vocalizations you make are going to require you to assume voluntary control of respiration. You might want to slow or hold your breath down to try to calm yourself. You might want to slow or hold your breath in a frightening situation. Imagine our wild ancestors, hunter-gatherers who had to deal with big predators and so forth that you don't have to worry about. Being able to quiet your own breathing when you're hiding from the predator, pretty good idea. Important survival reflex there. So primates are adapted to be able to do that. Furthermore, what happens if there's something noxious, a bad smell, smoke or something, Being able to hold your breath and stop breathing is a really useful way of protecting your lungs from noxious air intake. And finally, suppose you find yourself in a body of water. Humans are not inherently aquatic animals, but that means, among other things, we don't have a way to breathe in water. Therefore, being able to hold your breath is a vital defense for being able to survive in a body of water, whether that means that you dove in to grab some food or to swim across a channel of water that's blocking your way, or whether that means you simply fell in. All of these are situations that demand your being able to control your breathing. And therefore, we have this conscious override where we can step in and say, nope, I'm going to breathe faster or slower or stop breathing altogether right now. Now, try holding your breath. Try it right now while you're listening to me. I'm not going to do it because I need to keep talking, but hold your breath while you're listening to me. Holding your breath right now? Okay. At first, this is all right, huh? You can hold your breath for a bit. If you're a well-conditioned athlete, swimmer, you're probably accustomed to holding your breath for short periods of time. But I'm guessing by now you're starting to feel the burn, right? Getting a little bit harder. Longer you go, the harder and harder and harder it becomes to hold your breath. You begin to feel that kind of panicked, struggly feeling, like you need to breathe, you need to breathe. Something in your brain is trying to tell you, stop holding your breath. You can stop holding your breath. But my point is, and hopefully you have that experience now and you saw that, we can't maintain that indefinitely. The back brain is going to continue monitoring the conditions of gases in your bloodstream, and when you're holding your breath, carbon dioxide is accumulating. It's not being released, it's building up in your bloodstream, the pH of your blood is dropping, and that means you're getting signals from the chemoreceptors in your bloodstream going back to the brainstem saying, uh-oh, you need to step in, you need to do something about this, you need to change this up so that you're breathing. and eventually it will override your conscious impulse. It is technically possible to hold your breath until you pass out, but it takes a supreme effort of will, because for the overwhelming majority of people, at some point, the brain will override your attempts to hold your breath and force you to breathe in. Now, strong emotions can affect this as well. There's a strong connection between the limbic system, the emotional regulators of your brain, and your rate of respiration. This will cause hyperventilation in response to strong emotions, fear, sexual arousal, anger, sadness when you're crying. Not a conscious reflex, but it's a way in which the cerebral cortex can step in and affect your breathing rate. So that's the neurological control of breathing. How about the chemical control? There are chemical factors involved here, which should have been obvious from what I was saying just now. Chemoreceptors found throughout your body monitor the acidity of your bloodstream, that is the level of hydrogen ions, and will make changes accordingly. If the partial pressure of oxygen or CO2 in your bloodstream goes up or down, then your body is going to monitor that, and it's going to start to make changes accordingly. If blood carbon dioxide levels rise even slightly, the respiratory centers of your brain are going to increase the rate and depth of your breathing to eliminate carbon dioxide faster and bring in more oxygen. To put this in perspective, a 5% increase in the partial pressure of carbon dioxide in your blood will result in a 100% increase in your rate of breathing. That has a result of clearing out carbon dioxide, raising the pH of your blood. Anything that causes you to have pH of your blood get too low is going to result in labored breathing. If somebody is in diabetic shock, if somebody is experiencing ketoacidosis, then what's going to happen? They're going to experience so-called Kussmaul breathing, capital K-U-S-M-A-A-L, Kussmaul breathing, labored breathing, because that's an effort to bring in more oxygen, clear out CO2, and raise the pH to counteract the acidosis. Now, conversely, if your blood pH goes up significantly, if you're experiencing an alkalosis situation, that will lead to a reduction in your respiratory rates. That means that you retain more carbon dioxide, and that lowers the pH of your blood. Now, that can be dangerous, of course, if you're poisoned by something that's causing blood alkalosis, and your breathing rate begins to become too shallow. And as a result, you're not getting enough oxygen in. Hypoxia, that is the condition of insufficient oxygen, is only going to set in if the partial pressure of oxygen decreases to about 50% of normal. That is, on average, your bloodstream is carrying twice as much oxygen as you need, just sitting here at rest under normal conditions. You can have a 50% decline in the partial pressure of oxygen in your blood before you begin to have problems with hypoxia. So in other words, the rate of carbon dioxide exchange has a much bigger impact on your breathing rate than your rate of oxygen exchange. You can lose an awful lot of oxygen before it begins to hurt you. And that's an important adaptation to keep your cells furnished with the oxygen they need. Now, that said, if oxygen levels fall too low and you can't compensate, that's when suffocation happens. Suffocation, of course, is the situation in which you have insufficient oxygen and you begin to die because your cells are not furnished with the O2 that they need for, among other things, maintaining aerobic respiration, the production of ATP, as opposed to mechanical respiration, which is the action of breathing. Now, other things that can affect this. How about exercise? We've been talking about things at resting rate, how you are when you're just sitting at rest, like you are right now, breathing normally. I mean, maybe you're watching this on the treadmill, I don't know. But assuming that you go from low activity to high activity, you get up from your chair, you start running, doing something else active, your ventilation rate will immediately begin to go up. In response to demand of exercise, your body is going to say, uh-oh, we're going to need more oxygen shortly. And therefore, your rate of ventilation will immediately increase. About 50%, in fact, of the total increase in your respiratory rate that comes with exercise happens right away as soon as you begin. But as you continue exercising, your body slowly ramps up the respiratory rates, increasing the depth and pulse of your breathing. Now, this is fed in part by your brain, conscious awareness of the need. This is fed in part by proprioreceptors present in your muscles and joints, sending signals to the brainstem saying, hey, we're moving around more oxygen is going to be needed here shortly. Now, you're going to find that during exercise, your breathing rate slowly ramps up and then levels off, and then tends to hit a steady state when you're maintaining maximum aerobic respiration. Normally, that occurs about 4 to 6 minutes into exercise. For the average healthy adult, it'll slowly increase over about a 5-minute period and then level off. And you'll maintain a steady state there where your breathing rate will tend to hold steady for as long as you maintain the activity until other fatigue factors begin to set in. Now, here's the thing. Let's suppose you push beyond that. And this happens. Sometimes you're pushing beyond what you can maintain right here and right now. Suppose you're at that steady state, but you need to pour it on. You need to run harder. You need to work harder. Whatever is going on. And you force your body to go faster than your lungs can bring in more oxygen. We all have a maximum rate of oxygen uptake. It's based on the size of your lungs. It's based on the rate and depth of your breathing. It's based on the thickness of your alveolar membranes. But there's a maximum amount of oxygen your body can pull in at once. Once you hit that level, we call that your anaerobic threshold. Because if you move activity beyond that, in other words, if your cells are demanding more ATP beyond that point, and oxygen intake is not keeping up, well, you have no choice but to switch to anaerobic respiration. In other words, your cells begin engaging in an anaerobic process of lactic acid fermentation as a way of making more ATP to make up the difference. You can't maintain this indefinitely, partly because, first off, it's way less efficient than aerobic respiration, makes way less ATP. Secondly, because of the buildup, the waste product, lactic acid or lactates. As lactic acid accumulates in your muscles and is released into the bloodstream, it causes the pH of the blood to drop. You can go into a state of acidosis. And the dropping pH will eventually interfere with the chemical reactions involved in muscular action, causing muscular fatigue to set in. In the short term, lactic acid release will lower the pH of your blood, which will stimulate your brain to increase your respiratory rates. But you can only go so hard. There's a maximum rate at which it can go. Now, when you're engaged in athletic training, you can improve on this. Athletic training increases your vital capacity, raises the amount of air that you can breathe in and out. Your tidal volume and residual volume are going to change very slightly. The big things that change with athletic training: your vital capacity goes up. That is the maximum amount of air you can pull in and out of your lungs per cycle of breath. And your residual volume goes down. When you are exercising hard, that means that your lungs are contracting more forcefully, more air is being forced out, the residual volume drops, and that means the amount of dead air in your lungs drops. And that's good because more fresh circulating air coming in means more oxygen available for your lungs to take up. Average healthy adults. Exercising can raise your respiratory rate from about 6 liters per minute to about 120 liters per minute. If you really pour it on, maybe 150 liters per minute. Your well-conditioned athletes at the peak of human condition can achieve a minute ventilation of about 180 liters per minute. That is about the maximum that any human being can go. Part of this is expansion in compliance, improvement in compliance. Part of this is improvement in the conditioning of the muscles involved in respiration, allowing them to contract more forcefully and therefore more efficiently propel air in and out of the lungs. Your lungs themselves don't actually get all that much bigger when you're engaged in physical conditioning. One other effect of this is that when you're at rest, your minute ventilation, if you're a well-conditioned athlete, tends to go down. Remember how I said in the cardiovascular chapter that a well-conditioned athlete has lower beats per minute because you're getting more action out of each heartbeat, longer, more sustained contractions. And that means also that you can get away with longer breaths. You can breathe in more deeply, take in more oxygen per breath, and you'll find that in your best conditioned athletes, minute ventilation will fall slightly, but not a whole lot. At rest breathing is pretty much at rest breathing for everybody, and your oxygen needs at rest have never changed. So most of the difference you'll find in your well-conditioned athlete is in how far you can push yourself when you're really cold. All right, this is all the good stuff, right? Let's talk about some problems. First off, let's talk about the ones we're all going to face. Let's talk about the effects on the respiratory system as you age. All of us will experience a decline in respiratory function as you get older. Your vital capacity will go down, your maximum ventilation rate will go down, and your rate of gas exchange will go down. All of these are going to happen. A couple of reasons for this. One, the older you get, the more readily mucus accumulates in your lower respiratory tract. This is because the number of cilia present in the respiratory tract drops as you age. All of us are breathing in some kind of pollutants in the air. Even in the purest environments, there are natural pollutants present in the air, fine dust and particles that everybody inhales. And as you get older, that damages the cilia in your lungs. Loss of cilia means less efficient removal of mucus. Therefore, as you get older, more mucus will stay in your lungs more easily, and that reduces the amount of functional alveoli available for gas exchange. Furthermore, you will find that as you age, you're going to find that you're more prone to bronchitis and other respiratory infections for that reason. The fluid buildup there makes you more prone to bacteria getting in there. It makes it harder to clear out mucus. This is why older people, especially older people who are immobilized and not moving around much, are especially prone to pneumonia. You will find that as you get older, your minute ventilation is going to change a little bit. You're not going to be breathing as many breaths per minute. The muscles involved in breathing are not as strong as they used to be. You're not going to breathe as much, and you're not going to breathe as deeply. Your inspiratory capacity will drop because you're not going to be able to force those muscles to work as hard as they did when you were younger. This is further exacerbated by the fact that the costal cartilage, the cartilage associated with the ribs, tends to stiffen with age. And as a result, that means you can't expand the rib cage as much as you did before. All of that limits the amount of air an older person can take in as compared to what they could do when they were younger. Even if you're exercising as you get older, you will experience a decline because of these factors. You'll also find that as you get older, your alveolar ducts start to get stretched out. All elastic tissue in your body becomes less elastic with age, becomes more stretchy. It's why we get more wrinkly as we get older, but that includes the elastic tissue of the lungs. Your alveolar ducts become stretched out. Functional alveoli are going to be lost and damaged. This means that your gas exchange rate is going to drop as you age as well. Now, some of that is offset by an increase in tidal volume. Because older people have breakdown of elastic tissue, the compliance of their lungs actually tends to go up a little bit. So you can expand the lung a bit more than you could when you were younger, and that means you're taking in more air per breath. So the increase in tidal volume usually offsets some of the alveolar loss. But overall, it means you're not pulling in oxygen as well as you did before. Add this to the fact that anything that is going to be thickening that alveolar membrane is just going to make it worse on you. Respiratory illnesses hit older people harder, hit them for longer, and have a much greater chance of long-term consequences like pneumonia. That's the big danger for elderly folks, incidentally, both with the flu and with the coronavirus that we're all concerned about right now. That these viruses increase the rate of mucus accumulation in the lungs, and even for a young person, that can give you the risk of pneumonia. By the way, if you don't know that word, Pneumonia. Pneumonia is a respiratory infection characterized by accumulation of fluid in the lungs, choking out functional alveoli, reducing your capacity for gas exchange. It can be viral or bacterial in origin, and it can be lethal. And the older you get, the greater the likelihood of that happening for all the reasons I've discussed. Older people, quite frankly, cannot afford to lose as much of their respiratory capacity as younger people. A young, healthy person can get pneumonia, and as indicated previously, you can lose 50% of your oxygenation rate and still remain functional. So, a lot easier to bounce back from respiratory illness the younger that you are. Now, we can all experience some respiratory problems from time to time, and one that I've mentioned in here already that I wanted to talk about for just a moment again is a thing called bronchitis. Bronchitis is the inflammation of the bronchi or bronchioles. Sometimes you'll hear bronchiolitis for inflammation of the tiny airways, the bronchioles. This can be caused by environmental irritants. Pollution can do this. Cigarette smoke can do this. It can also be caused by infection, bacterial or viral. Bronchitis leads to swelling of the lining of the bronchioles. Swollen tissues have increased mucus production. You got more fluid in the lungs, and that reduces the movement of the cilia, making it harder to clear that mucus out. Inflammation constricts the bronchi. Bronchoconstriction means narrower passageways. Air can't get in as easily. You have to fight to breathe more. And therefore you find yourself very fatigued because you're not bringing in as much oxygen. Bronchitis is a common consequence of respiratory illness. Usually you can clear it by rest and, if it's bacterial in nature, taking an antibiotic to help with that. Now let's suppose, however, that you're a smoker. I don't have to tell you guys that smoking is bad for you. You all know that already. That's basic common knowledge by now. But now you're in a position to understand why. When you're smoking, you're putting these irritants into your lungs. You're causing more mucus secretion. You're damaging functional ciliae, which means that it's harder to remove that mucus. You're causing more irritation, which means more cough reflexes. The more you're coughing, the more inflammation you're likely to experience from irritation of the trachea and the bronchi. Furthermore, the tiny pollutants getting into your lungs, along with that cigarette smoke, are effectively reducing your numbers of functional alveoli. They're irritating the alveolar membranes, causing those membranes to thicken so you have less gas exchange capacity, and causing the surface area available to exchange gas to be reduced by the accumulation of tars and fine particulates from the cigarette smoke. As your number of cilia goes down, the only way to effectively clear the mucus is by forceful coughing. And of course, that can lead to chronic irritation, a condition we call chronic bronchitis, whereby you have lasting bronchitis, basically because you've gotten into a cycle of increased coughing as the only effective way to clear mucus. The more smoke you have moving into the respiratory passages, you thicken the respiratory membranes. The alveoli, the simple squamous epithelium, begins to stratify in an effort to protect against the irritants. And that makes it harder to take in oxygen. Chronic bronchitis, in and of itself, is pretty bad, but it can get worse. Over time, the consequences of chronic bronchitis can lead to the loss of more and more functional alveoli until you get into a situation called emphysema. E-M-P-H-Y-S-E-M-A. Emphysema is characterized by the destruction of the alveolar walls. It's a progressive condition because it puts more strain on the remaining alveoli. As the alveolar walls are increasingly destroyed, then you're going to end up with harder and harder time getting mucus out of there. You're going to have more strain on the existing ones, which leads to more alveoli being destroyed, leads to a chronic shortness of breath, and the gradual death of functional lung tissue. It's a progressive condition, and at present, there's no cure. By the way, the combination of emphysema and chronic bronchitis, which is a common combination that ends up afflicting long-term smokers, is a condition we call COPD, chronic obstructive pulmonary disease. You've all heard of COPD. We have drugs to treat it. We cannot presently cure it. And as a result, eventually, if something else doesn't get you first, it will. Emphysema will cause the loss of portions of the lungs, which will eventually have to be surgically removed. Of course, that gives you less lung capacity to work with to begin with, and you can see why that you get into a snowballing effect here. Now, you're somewhat offset because as the lung tissue begins to die, compliance goes up. You can stretch the lungs out more, but that's not going to help you for long. Eventually, that's not going to be a good thing anymore. Oxygen treatments can help. You've all seen people with emphysema who have that little oxygen tank on a cart. If you're putting a larger amount of oxygen into the lungs, if the volume of air in your lungs is more oxygen than it was otherwise, then you can get the most bang for your buck out of each breath. In other words, you can increase the amount of oxygen coming in so that your remaining lung tissue has more oxygen to work with. And that's what that oxygen tank and the little cannulus that goes in your nose is for. You can also do some breathing retraining to help slow the progression. But in the ultimate, again, COPD, emphysema, there's no cure. All right. Now, I talked about asthma previously. In our discussion of hypersensitivity disorders, I talked about asthma in some detail. It's probably the most common respiratory disease in America. It's estimated that 1 in 4 people might experience asthmatic symptoms at some point during their lifetimes. The condition is more common in children and juveniles than it is in adults. A lot of kids who are asthmatic when they're young will lose asthma as they age. It is also possible to develop it as you get older. We believe that's a result of environmental antigen exposure, pollutants, allergens, and so forth. We do not know why asthma gets better in some people over time, why it gets worse in some people over time, why some folks are born with it, and why some people don't get it till later. There does seem to be a genetic predisposition. The tendency for asthma seems to run in families. I am quite happy to testify that's the case in my family. I've got a lot of asthmatics there. And it's characterized by episodes of extreme bronchoconstriction, in which the bronchi become very constricted. It becomes harder to breathe. You experience that labored, wheezing quality with the breathing. Asthma attacks can be higher or lower. You can have low-grade asthma symptoms with minor bronchoconstriction, or you can have a quote-unquote asthma attack, a more intense episode. Causes of asthma are quite numerous. Exposure to environmental pollutants and allergens will commonly stimulate asthma symptoms. Some asthmatics are sensitive to changes in weather, particularly drops in temperature can often cause significant problems with asthma. There's exercise-induced asthma, in which those bronchospasms are induced whenever you're engaged in a high level of physical activity. Some asthmatics experience symptoms accompanied by emotional stress. Emotionally induced asthma attacks are a thing. And low-grade asthma trouble can be a product of chronic stress. Any given asthmatic might get any of those, or in my case, all of those. Primary treatments is the introduction of inhaled corticosteroids, which reduce inflammation in the lungs and have the effect of opening the bronchioles. Things like your albuterol-type inhalers. Some asthmatics have a maintenance inhaler that they use regularly to keep symptoms down on a strong basis. Most will have rescue inhalers that are used to introduce a quick puff of those steroids when needed. You also have more intense breathing treatments, nebulizer treatments that give a larger concentration of corticosteroids at once for times when you're having severe symptoms. Asthma in and of itself is a manageable condition, but asthmatics are going to be much more prone over time to serious respiratory illness, things like, of course, pneumonia or chronic bronchitis or what have you. Needless to say, if you're an asthmatic, smoking is an even worse idea for you than if you're not. But we can't talk about smoking and we can't talk about respiratory illness without saying a few words about bronchiogenic cancer. bronchiogenic. bronchiogenic, bronchiogenic cancer. The term bronchiogenic cancer is a catch-all term for any of the cancers of the respiratory tract. That can mean lung cancer. That can also mean so-called neck and throat cancer, in which the cancer is found in the linings of the trachea or the pharynx or the larynx. Most commonly occurs in the lungs, but can occur elsewhere as well. Bronchiogenic cancer is a cancer of the epithelial tissue, that is the constantly dividing epithelial cells that line the respiratory tract. It is the most common cancer in the United States and the most common cause of cancer death. The overwhelming majority of cases of bronchiogenic cancer are directly correlated with exposure to cigarette smoke. And that can mean smoking yourself, that can mean secondhand smoke. Other environmental pollutants are a possibility, but most people are not living in an environment that is so heavily polluted that it will significantly increase their cancer risk over time. But places like Los Angeles that have very chronic problems with high levels of air pollution, the levels of bronchiogenic cancer are higher. But the single biggest risk factor is smoking. 75% of sufferers of bronchiogenic cancer are active smokers. That does mean you can get it without, but the overwhelming majority of cases are tied to it. Now, bronchiogenic cancer is an especially nasty animal because a lot of times it doesn't show any obvious symptoms for a while. If you're getting it, odds are pretty good you already have at least chronic bronchitis. You already are probably suffering from some impaired breathing because of it. Therefore, loss of capacity due to your growing cancer may not attract your attention. It may look to you like you just have a long-lasting cold or something, even if you're just having a persistent cough, difficulty breathing over time. And remember that you can lose 50% of your oxygen carrying capability before hypoxia becomes a problem for you. This combination of factors means that unfortunately, bronchiogenic cancer is often not caught until it's already quite advanced. And that, more than anything else, is why it is such a lethal cancer, because a lot of times by the time we know you have it, you are already quite advanced in its progress, and it may have already metastasized. Speaking of, the fact that our lungs have such a rich blood supply coming in, and because they have so many lymph nodes associated with them, providing significant lymphatic drainage to keep fluid levels around them low. Those two factors mean that cancer cells that develop in the respiratory tract spread really easily to other parts of the body. So lung cancer has a very high rate of metastasis, of spreading from its original locus to new locations. We have learned that a lot of folks are genetically predisposed to respiratory cancers. If you have family members who have had them, you're at much higher risk. I can see this in my own family. My mother's side of the family, they all smoke like chimneys, and most of them die of neck, throat, or lung cancer. My dad's side of the family, they also smoke like chimneys, but they tend not to get it. They don't seem to have the genetic predisposition. But make no mistake, folks, even if you have no family history, anyone can develop a cancerous mutation. And yes, it is technically possible that you can end up with a bronchiogenic cancer without being a smoker, but the overwhelming majority of cases are tied directly to that. So, if you've got a genetic predisposition, this is a thing you're going to have to keep an eye out for, even if you're not a smoker. If you have no known genetic predisposition, the smartest thing you can do is quite simply don't smoke. Well, really, don't smoke, period. You've seen it has a lot of problems. Even if you don't get cancer, it can lead to chronic bronchitis and COPD and emphysema. You have that nasty smoker's cough all the time, which isn't a lot of fun. It makes you more prone to other respiratory infections, makes you less able to have endurance when you're exercising because of chronic irritation of the lining of the lungs. And let's be honest, for the cost of what you spend on cigarettes every year, you could bank that and take a pretty nice vacation. Bottom line, folks, don't smoke. I've been telling you that for years. Everybody's been telling you that for years. Well, I've not been telling you that for years. I'm telling you right now. You've got some reasons now, if you didn't before. And on a personal note, let me add one last thing with that. Plenty of people I've heard say over time, gotta die sometime, right? I'm gonna die of something eventually. Why not just enjoy the cigarettes while I'm here? I've never heard that from somebody who has watched someone die of lung cancer. I've watched a lot of people die of lung cancer. It is a slow, painful, terrible, choking, gurgling, nasty death. You do not want to die that way. Yeah, we're all going to die eventually. Put it off as long as you can, and don't make it by cigarettes. You won't like it. All right, so that concludes my survey of the respiratory system. That includes a look at some common respiratory pathologies. That includes a look at the way we regulate breathing and some of the effects of both exercise and aging on our respiratory rates. And that wraps up my chapter on the respiratory system. Hope you've all enjoyed. We will follow up with new topics now that we've finished the respiratory system. My next subject is going to be the urinary system. So we'll move on to that in the near future. Have a good night, folks.